Hello friends, welcome to next Saviours Essential Question Series for NEET PG 2025. In this session, I'll be talking about a very important topic, that is inguinal hernia. As you all might be knowing that several questions are asked in your examinations with regard to this topic, and commonly asked questions are usually pertaining to the anatomy of the inguinal region. There are certain named hernias which are commonly asked, and finally, the treatment options that we have at our hand for treating such a condition. So, with the help of this question, we will be trying to cover this topic. So, we have a 70-year-old male with a 10-year history of right inguinal hernia, which he was traditionally been able to reduce at home. So, this gives us a First of all, the diagnosis is clear that patient is suffering from right inguinal hernia and which was reducible for the past 10 years. But now the patient has presented to the emergency department with 12-hour history, that is a short history or acute history of severe right groin pain. So that means that some complication has occurred in the patient. So now he is saying that the hernia, which usually cause minimal discomfort but has become irreducible now, and is associated with marked tenderness. In addition, he has experienced multiple episodes of vomiting, and he notes that the abdomen is also distended. On examination, there is fever, there is tachycardia, BP is on the lower side. On inspection of the right groin, there is firm tender mass with overlying skin erythema. Now, on abdominal examination, there is diminished bowel sounds and diffuse distension. On laboratory, there is leukocytosis, and CT of the abdomen is shown here. Okay, so CT scan, we can see that this is the inguinal hernia, which is obvious here in the CT image, and we have bowel loops present inside the hernia. Okay. What all options do we have? So, is it an incarcerated hernia? Incarcerated hernia causing small bowel obstruction, or is it an strangulated inguinal hernia leading to ischemia, or is it a reducible inguinal hernia, or is it a sliding inguinal hernia? So, before we discuss this question, I'll be talking about the anatomy of the inguinal region so that you are able to solve all the probable questions that are asked in your examinations. So before jumping to the inguinal region anatomy, I'll just go through the anatomy of the abdominal wall first. Okay, so abdominal wall, as you all know, it's this is the figure here of the abdominal wall where we can see that in the midline. Okay, in the midline extending from the xiphy sternum here up to the pubic bone, we have a fibrous structure which is called as linea alba. Okay, on both sides of the linea alba, we have two muscles called as rectus abdominis. This forms the medial most compartment of the abdominal wall musculature. On the lateral aspect, we have muscles, that is external oblique, followed by internal oblique, and followed by transversus abdominis. Now, to give you a more clear perspective, I have made a cross-sectional view of the abdominal wall musculature, which will help you in understanding the anatomical relationship of these muscles and aponeurosis amongst themselves. So in the midline, we have linea alba. On both sides of the linea alba, we have rectus abdominis muscles. On the lateral aspect, we have these three muscles called as external oblique, internal oblique, and transversus abdominis. Now, like there is linea alba, which is a fibrous layer which is formed by fusion of both the anterior and the posterior recti sheath. We have on the lateral aspect another line called as linea semilunaris. And what is this linea semilunaris? So basically what happens is that these lateral compartment muscles, that is external oblique, internal oblique, and transversus abdominis, they have their own aponeurotic sheaths which fuse at the level of linea semilunaris, and then they give slips to the rectus abdominis muscles, so that on the anterior aspect we have anterior rectus sheath, which is formed, and on the posterior aspect we have a posterior rectus sheath. Okay, so these sheaths are basically the extension of the aponeurotic sheaths of the internal oblique, external oblique, and transversus abdominis muscle. When we go further deep, we come across a fascia called as a fascia transversalis. This is a very important fascia because it covers the entire abdominal cavity from the inside. Further deep as we go, then we encounter the peritoneum along with the preperitoneal fat. Now, a few things about about this anatomy here, that this is not consistent throughout the anterior abdominal wall. Somewhere in between the umbilicus, somewhere in between the umbilicus and the pubic bone, somewhere here, the posterior rectus sheath gets deficient. Okay, so this is the actually the lower extent of posterior rectus sheath, which is called as the arcuate line. Okay, so beyond this, so we have the posterior rectus sheath up to this point, and beyond this, there is no posterior rectus sheath. This is important. This is important because it has been asked in your examinations several times. Okay. Now, since this is clear, we will now come to the anatomy of the inguinal region. So, as you all know, that the inguinal region is the lowermost part of your abdominal wall. Here I have already made a diagram. On this side, that is on the right side, I have made a diagram where we have divided the skin and the subcutaneous tissue. Okay, and we have come across, so we have divided the skin and the subcutaneous tissue, and what is visible now is the external oblique aponeurosis. So we have the anterior superior iliac spine and the pubic tubercle. Between the ASIS and the pubic tubercle is a fibrous structure which is called as inguinal ligament. Okay, so this is the inguinal ligament, and this is the external oblique aponeurosis. So we will further discuss about the inguinal ligament. Now, what we have to understand at this level is that at the level of the external oblique aponeurosis, there is a deficiency, or there is a deficiency here which is called as the superficial inguinal ring, which is actually a deficiency in the external oblique aponeurosis. And it is this ring through which the spermatic cord exits and enter into the scrotum. Okay, so it is through this external or superficial inguinal ring that spermatic cord exits the inguinal canal and enters into the scrotum. Now on this side, that is the on left side of the diagram, I have what I have done is, after cutting this, after dividing this external oblique aponeurosis, what we see is, so what we see is the spermatic cord or the inguinal canal. Okay, inguinal canal, and we see the ring here which is called as the deep inguinal ring. So what happens is that during the development, the testicular vessels, they enter into the scrotum via a deficiency in the fascia transversalis, which is called as the deep inguinal ring. This is the inguinal canal region, and the content of the inguinal canal is the the content is the spermatic cord, which enters into the inguinal canal via the deep ring and exits here via the superficial inguinal ring into the scrotum. Okay, so to give you a more clear perspective, I have drawn a cross section at this point, which is this. So what we see here is that this area here, this is the inguinal canal region with spermatic cord, and the boundaries of the inguinal canal are on the inferior aspect. This is the inguinal ligament. So as you can see, what exactly is the inguinal ligament? So it is the shelving edge of the external oblique aponeurosis. Okay. So so just try to understand this diagram here, that we are seeing from the anterior aspect. So this is anterior and this is posterior here. Okay. So this is the posterior aspect, this is the anterior aspect. So from anteriorly, when we go in, we cut the skin, there is skin, then there is subcutaneous tissue, and then we come across a sheath which is called as the external oblique aponeurosis. Now this external oblique aponeurosis, it covers the entire abdominal wall on the anterior aspect. It on the caudal aspect, on the that means on the inferiorly, as it goes, it shelves around itself and forms a shelving structure which is called as the inguinal ligament. Okay, so this is the inguinal ligament, and what it houses is the inguinal canal, which contains the spermatic cord in the male and round ligament in female. Okay, now several times the question has been asked about the boundaries or the anatomy of the inguinal canal region. So as you all can see, on the anterior aspect, inguinal canal is covered by the external oblique aponeurosis. On the inferior aspect, it is covered by the inguinal ligament, which itself is a shelving edge of the external oblique aponeurosis. Superiorly, we have these two muscles, that is the transversus abdominis and internal oblique. These forms the superior aspect of the inguinal canal region, and this, when they are both combined just above the region of the inguinal canal, this is also termed as the conjoint tendon. So conjoint tendon is nothing but the musculo-aponeurotic musculo. So conjoint tendon is nothing but the musculo-aponeurosis of both transversus abdominis and internal oblique. When they are combined, it is called as a conjoint tendon. Okay. Now coming on to the floor, that means on the posterior aspect, the floor of the inguinal canal is formed by fascia transversalis. Okay, so this is formed by fascia transversalis, and on the inferior aspect of the fascia transversalis, it gets thickened. This area here, it gets thickened. It is called as the iliopubic tract. Okay, so this is an important structure here. It runs entirely from the ASIS up to the pubic tubercle. That means it runs posteriorly to the inguinal ligament region. It runs posteriorly to the inguinal ligament region into the entire length from ASIS up to the pubic tract, pubic tubercle. Now, here we will also discuss about the contents of the spermatic cord, as it has been asked several times in your examinations. So we have already made the diagram of the spermatic cord. So what is a spermatic cord? So basically, spermatic cord is it runs in the inguinal canal, that is from the deep inguinal ring up to the superficial inguinal ring, and then it exits the superficial inguinal ring to come into the scrotum. Okay, so the contents of the spermatic cord are: externally there is an external spermatic fascia, then there is cremaster muscle. Now this cremaster muscle is nothing but it is derived from the internal oblique muscle. This has been asked in your questions. Then there is an artery to cremaster, which is a branch of inferior epigastric vessel. Then as we go deeper, we have the internal spermatic fascia. Okay. Now inside this fascia, we have several structures. That is, so we have a vas deferens along with an artery to vas. Then we have a testicular vessel, testicular artery. Then we have the genital branch of genitofemoral nerve. Then we have pampiniform plexus. Okay. Now there is one more structure which enters into the deep inguinal ring and exits at the superficial inguinal ring, but it runs outside the spermatic cord, and this is that structure which is called as ilioinguinal nerve. Okay. So you need to remember these very thoroughly. The contents of the spermatic cord, the boundaries of the inguinal canal, the content of the spermatic cord. Now further as we go deep, okay, so this was the first, this is the first thing that we encounter, that is the external oblique aponeurosis. After cutting the external oblique aponeurosis, we see this structure here, that is the region of the inguinal canal and the muscles. Now if we further go deeper, what we see is this. So this is actually at the level of the fascia transversalis or at the level of the deep inguinal ring. So just medial to the deep inguinal ring is a very important landmark called as inferior epigastric vessel, which serve as a landmark for both for surgical management as well as for the purpose of our diagnosis. Now, any hernias which occur lateral to the inferior epigastric vessels are termed as indirect or lateral hernias, and any hernias that occur medial to the inferior epigastric are termed as direct or medial hernias. Okay. Now, inferior epigastric vessel by itself is a branch of the external iliac vessels, and it runs and it runs into and it runs sorry so inferior epigastric vessels are the branches of the external iliac vessels, and it runs on the towards the anterior abdominal wall to supply the rectus muscle. Okay. Now here we will also discuss about the area that is the direct inguinal hernias. So as you can see, this area here, this area here is termed as Hasselbalch triangle, which is bounded by, on the lateral aspect we have inferior epigastric vessel, medially we have the rectus abdominis muscle, and inferiorly we have the inguinal ligament. And this Hasselbalch triangle is the area where direct inguinal hernia occurs. Okay. So this is again a very important thing which you need to remember. Now we will also discuss about the very important topic, that is the femoral ring or femoral hernia. Now, as you all might have seen and noticed by now, that all the hernias, that is both the direct hernias as well as the indirect hernia, they occur above the level of inguinal ligament. Okay. So both of these are above the level, above this level. Now there is, because of the deficiency here in the infrainguinal region, there is this area here, this area which is a area for femoral hernia, and this is, what is this? So this femoral ring is bounded by, on the medial aspect we have lacunar ligament. Okay, you need to remember all this. We have lacunar ligament. Laterally you have femoral vein. Anteriorly, you have the inguinal ligament, that is this. This is the inguinal ligament along with iliopubic tract, and on the posterior aspect, you have the Cooper's ligament. Okay. So this is the area of the femoral ring where femoral hernias occur. An important point about femoral hernias are, as you can see, that this is basically a very tight ring, and so femoral hernias have a very high propensity for development of strangulation of any hernia that occurs here. Now, with the advent of laparoscopic surgery, hernia surgeries are now very commonly done laparoscopically. How is laparoscopic anatomy different from the open anatomy? Is that, see, via the laparoscopic surgeries, we are approaching from the posterior aspect. Okay, so we need to know everything from the posterior aspect. That means from inside the abdominal wall to outside. And so this is a diagram or a photograph of an intraoperative hernia surgery. What we can see, what you all need to remember is that there are certain landmarks which are which you see once you go inside the abdomen. So in the midline here, we have this structure which is called as the median umbilical ligament, which is actually the urachus, that is obliterated urachus. Then we have medial umbilical ligament. You can see this peritoneal fold here. This is the medial umbilical ligament. What is this? This is the obliterated umbilical vein. And then further lateral as we go, then we see this structure here, which is seen in this diagram very clearly. This structure here, this is termed as the lateral umbilical ligament. And what does it contains? It contains the inferior epigastric vessels. Okay. Now, this is the area, inferior epigastric vessel. So, as you all might remember, that any hernia that occurs lateral. So, this is the area here. This is the area here. You can see this area here, or very clearly seen, this is the inguinal hernia. And this is the area of the deep inguinal ring. So, this is an indirect hernia. And you can see here, this is the inferior epigastric vessel, which is serving as a landmark for defining the indirect and direct inguinal hernia. So you need to remember a few things over here. First of all, what is the median umbilical ligament? Several times questions have been asked. Medial umbilical ligament contains obliterated umbilical vein. Then inferior epigastric vessels are contained in inferior epigastric vessels are present in the lateral umbilical ligament, and they serve as a landmark for defining the indirect versus the direct inguinal hernia. Okay. Now again, some important structures or some important triangles which you need to remember for laparoscopic surgery are, this here is the triangle of doom, which is bounded medially, that is this structure here. This is the vas deferens. On the lateral aspect, we have spermatic or gonadal vessels. And here the base of the triangle is formed by the peritoneal reflection. Why it is called as triangle of death? So just as you can see here in this triangle, here are the major vessels crossing, that is the iliac vessels. Okay, so the external iliac vessels are just beneath or just beyond this triangle here. So why is it called the triangle of doom? Because it contains here the major vessel, that is the iliac vessels. So any injury in this area, or if you accidentally injure any structure here, may lead to torrential bleeding and can lead to death. Now on the as we go lateral to the triangle of death here, this is the area of several nerves which pass through, and this is called as the triangle of pain. Okay, so the triangle of pain, it is bounded by, this is the iliopubic tract. On medially we have gonadal vessels, and it contains several nerves. For example, it has the lateral cutaneous nerve of the thigh, the femoral branch of the genitofemoral nerve, and along with the cord structures, we have ilioinguinal nerve and genitofemoral nerve, that is the genital branch. All these nerves, they pass through this structure. So while fixing the mesh, we have to avoid putting any tags or sutures in this area, because it may lead to nerve entrapment and may lead to chronic pain. So I hope the anatomy of the inguinal region is clear to you all. Now we will come across the question again. So what we have here, we have a 70-year-old man with 10-year history of inguinal hernia. It has suddenly become irreducible. It has suddenly become irreducible, and there is marked tenderness. There is history of vomiting. There patients are is showing toxic signs. That is, there is fever. There is tachycardia, BP is on the lower side, and on examination, a very important finding here is that we have the overlying skin which is erythematous, and there is a tender mass. Okay, so which of the following is the condition of the which of the following best describes the condition? So first of all, what is incarcerated hernia? So now we in this question we are talking about the complications that may happen in a patient with inguinal hernia. So, what all complications? So, incarceration. What does incarceration means? So, incarceration is nothing but irreducibility because of a long history, a very long history of inguinal hernia. There, several adhesions. So, because of a long history of inguinal hernia, what happens is that several adhesions form between the hernia sac and the content. So, it these adhesions, they prevent the reduction of the hernia content, and hence they become irreducible, which is termed as incarceration. Now, how is incarceration different from strangulation? So, in incarceration, there will not be no vascular compromise of the content. Okay, so vascularity of the content will be intact. There won't be any vascular compromise. Only thing that happens is that hernia, which was previously reducible, will now not reduce while sitting or while lying down, or even when the patient tries manually. So, what happens in a strangulation hernia? So, in all the patients where, so strangulation is when the content has diminished or compromised vascularity. Okay, whenever the content has diminished or compromised vascularity, it will lead to strangulation of the content. Now, this strangulation will present as whenever we have the intestine or the bowel as the content. This will present as there will be signs of, first of all, localized tenderness will be there. There will be severe pain. Patients may present with obstruction Obstruction means there will be abdominal distension, there will be vomiting, there will be severe pain in abdomen, there will be obstipation. Obstipation means inability to pass both feces as well as flatus. Okay. Then on examination, we may have localized tenderness, and on vitals of the patient, there will be signs of toxicity. That is, there will be tachycardia, there may be hypotension, and there will be increased TLC in these patients. Okay. So this is one complication. Another important complication is obstruction. So what happens is that suppose this is a hernia with a constricted or a small neck. So whenever bowel will come here, and because of this constriction, these patients, there will be a obstruction in the outflow and inflow of the content of the intestine, which may lead to obstruction, which will again present as severe abdominal pain. There will be abdominal distension, there will be vomiting, and there will be obstipation. Okay, so we will come again to our question. So I think it is now clear. And one more thing is how to diagnose a inguinal hernia. So diagnosis of an inguinal hernia or any hernia is basically clinical, where you need to see a swelling, which is most of the times reducible, and on cuffing there the swelling will appear. So there will be a expansile cuff impulse. Okay. So there will be history of swelling that appears when the patient strains, which may be while coughing or while standing for a prolonged time or while passing stool. In such cases, whenever there is increase in abdominal pressure, the swelling will occur. And when the patient lies down, the swelling will go. But in cases of complications, as we have just discussed, that is whether there is incarceration, in those cases, the swelling won't get reduced. And in such cases, we need to take help of some investigations. So the commonly done investigations are a USG abdomen or a CT scan of the abdomen. CT of the abdomen is mainly required to know the complications of the hernia, whether anything has happened. For example, in this CT image here, that we can see here that this is the hernia, and there is bowel content here. This is the bowel, and moreover this is a contrast enhanced image, and the bowel wall here is not enhancing as it should. So that is the sign of strangulation or a vascular compromise. Okay. So again, coming to the question, so we have seen a patient with signs of toxicity. There is hard tender mass, and there is overlying erythema with leukocytosis. So we are probably dealing with a strangulated inguinal hernia. Now we will also discuss the other options here. So incarceration, as you all know, does not involve vascular compromise, reducible. As you all know that there is a history of reducibility for past 10 years, but presently it has become irreducible. And then there is another term here which is called as a sliding inguinal hernia. So what is a sliding inguinal hernia? Sliding inguinal hernia is a hernia where one of the wall of hernia is formed by a viscus. Most commonly on the left side it is the sigmoid colon, on the right side it is the cecum, and there may be urinary bladder on both sides. Okay. Now coming on to the treatment. So for strangulated hernia, we need to explore the patient after, of course, initial optimization, that is initial IV fluids, antibiotics. We have to take up the patient for surgery. If required, we have to do the resection of the bowel in cases where gangrene has already occurred. And In non-complicated hernias, that is reducible hernias, we have three options: tissue repairs, which is bassini repair or the shoulders repair. These repairs are usually not done nowadays because they used to have a higher rate of recurrence. Nowadays, mesh repairs are usually done, and Lichtenstein tension free mesh repair is the treatment of choice for most cases. Now, with the advent of laparoscopy, laparoscopic repairs are commonly being performed for these hernias, and commonly used techniques are extraperitoneal, and this is termed as TEP, that is totally extraperitoneal, and the other one is TAPP, that is trans abdominal pre-peritoneal approach. So, friends, I hope this is all clear regarding the inguinal hernia. The important topics which you all should remember about this topic is the anatomy of the inguinal region, how to diagnose a case of inguinal hernia, how to diagnose the complications of the inguinal hernia, and in the end, the treatment that all the treatment options that you have for the management of inguinal hernia patients. Thank you.